Lynne and Jason have done a great job, okay, and I have only just to point out some of the differences for the children. Okay, so we're going to discuss infective rhinosinusitis, and I'm just going to point out a little bit of differences for children. In a child, it is definitely more difficult to get a history. Yeah, everything is by proxy, and sometimes the parents are not at home, and we depend actually in Singapore a lot on the maid, okay, to give us a good history. The extent of the investigations, of course, will also be more difficult. Like doing a flexible endoscopy is easy in an adult, but it's difficult in a kid. And also the parents are more concerned about X-rays, radiations, yeah. And there's I think what is most disturbing, however, is that there's a very, very significant lack of high-level evidence. Not because we don't want to do trials and all that in children, but it's difficult to actually enroll a child, and there's a lot more protection and all that put into place. When you actually see something with a grade D evidence, it does not mean that there is no evidence. It may mean that the best evidence available is only maybe a case report, a case series, and so it's a grade D, alright? So I think that's a big thing that we have to remember as we look into this compared to an adult. The guidelines are guided also by the EPOS paper, and we know that for a young kid, less than 10 years old, there's immature immunity, there is adenoid hypertrophy, there is significant increase in the incidence of allergic rhinitis. In some populations, even about 40% of children actually in the population have allergic rhinitis. So it becomes very difficult to actually differentiate between a cold, between flus, between allergic rhinitis, adenoid hypertrophy. Yeah, everything would come with nose block, with rhinorrhea. The bacteriology is strep pneumonia, Haemophilus. In children, a little bit more of the Morozella catarrhalis. That's an acute rhinosinusitis. For the chronic rhinosinusitis, there have also been other bugs which includes also anaerobe. But we know in the settings, in the hospital settings and outpatient settings, when you send something for anaerobe culture, very frequently it comes back negative, but that may be because we are not culturing it in the correct way, not stringent enough, okay, in the cultures. So the differences have been alluded to already, yeah, so I'm not going to go through this slide. So the guidelines for the GPP guidelines are that the allergic rhinitis often coexist with rhinosinusitis. So in the history and the examination, we have to really look into allergic rhinosinusitis. We look into not only inhalant allergies, but also food allergies. And for a child, especially important if it's a unilateral blockage rhinorrhea, exclude foreign body. Because it is a child, don't just think that there cannot be tumors, alright? We have found actually rhabdomyosarcomas, yeah, we have found polyps in a child, and like the rhabdomyosarcomas, missing it by 4 months actually makes a huge difference to the prognosis of the patient, right? So do take a look into the nose. And rapid and serious complications are possible. For example, the most common that I see in the hospital from misdiagnosis complication, the orbital infections. Later I'll just show you some. And the important thing to remember is that they can come without any history, without any complaints of a nose block, of rhinorrhea, alright? An orbital complication can be the first presentation in a kid of acute rhinosinusitis. So especially for a child, otitis media with effusion is extremely common. And so anybody with a rhinosinusitis, allergic rhinitis, we have to, in every examination, look into the ear. You know, these pictures that are often shown to you are beautiful pictures, very unfair pictures, because we use an otoscope, you know, a nice endoscope with extremely good lighting, and we take pictures like these. So when you get to the clinic, don't see this and you think it's not otitis media with effusion. But the otitis media with effusion in a kid would actually just look a little bit loss of translucency. Yeah, you may not see such nice bubbles and yellow eardrums. In acute settings, you see a bulging eardrum, and you see whitish that could be pus. It's under pressure, so it's painful. Under 2 years of age, we have to actually remember to exclude a mastoid infection. A mastoiditis in under 2 years old can be actually an emergency, right? You have to admit for sometimes IV antibiotic, and sometimes we need to do surgery. So in the ENT clinic, we have a small pediatric endoscope, 2.9 millimeter as compared to the 4 millimeter of the adult, and we look for the same sign. Topical decongestion is very important for nasal endoscopy. After decongesting, we want to wait for a suitable amount of time, and if we wait long enough, sometimes the mucopus would actually show themselves, alright? And every child actually can be endoscoped. It's just whether they start screaming in your ear and whether you can hold them down, yeah? When they are below 3 years of age, you still can hold them. When they are 5 and they start kicking, it's a bit harder, but every child can actually be endoscoped. So the investigations, many of us would try to take a little swab from the front of the nose, but actually that is not very representative. It is not representative, and what you actually need to do is to get it from the middle meatus at least, yeah, if not a sinus aspirate. The imaging, like the adults, is not routine, and again in a kid, extra care because of radiation issues. So this is a child with a proptosis of the eye. No rhinosinusitis complaints whatsoever. No history of allergic rhinitis, no nose block, 2-day history of swelling in the eye. Alright, and this kid actually had cystic fibrosis, and on this scan, there's actually a mucocele in the moidal area, and it's compressing inwards into the orbit orbit and proptosing the eye. Other children may actually have unilateral, you can see unilateral sinusitis and then proptosis of the eye. It's quite interesting. In this proptosis cases, many times we may see that the sinusitis is only unilateral. In a kid with chronic rhinosinusitis, something that is very difficult to treat, again, important to look for allergic rhinitis. In the evidence base, they say it's controversial, but definitely for myself in my practice, I see it very commonly that if I treat the allergic rhinitis, the chronic rhinosinusitis is helped. All right, and again, in my practice, I see that if there is no inhalant allergies, you may also want to look into food allergies. Immunocompromised state, the thing to note is that rhinosinusitis is actually the most common presentation of an immunocompromised state. And this could be primary due to immunoglobulins deficiencies, but it could also be due to transplants, drugs, HIV, malignancies, and we would see that a lot more in tertiary settings here in the hospitals. And they get very unusual bugs and microorganisms, even fungi. This is a kid with a chemotherapy done for leukemia. He had pneumonia, he had septicemia, he was obviously getting a bacteria septicemia. Over about just 2 to 3 days, there was a little bit of change in color over the dorsum of the nose and just a little bit of discoloration. And so initially it was thought that it was due to the nasogastric tube that was taped to the nose and pressuring on the nose. But over 2-3 days, it actually broke down and a scab showed itself here, and it was actually very invasive fungal sinusitis. Okay, and so this is high mortality, so it has to be diagnosed as early as possible. The other thing which is not so much mentioned in adults, rhinosinusitis, is actually reflux. So for a very young child, especially those with below 2 years of age, and certainly for somebody below 1 year of age, reflux can really go right up to the postnasal. And I have seen this commonly when I scope the patient. We have seen enough to tell what is an adenoid and what is an adenoid with reflux. They look very different. This looks really edematous, and when you scope further down, you can also see it in the larynx, okay, edema in the larynx. And when I treat reflux, sometimes rhinitis gets better. All the sniffling in the nose and all that, okay, actually get better. And adenoids is actually not very common in somebody below the age of 2 years old. So if you see a child with an adenoid below 2 years of age, you have to actually exclude reflux. Some people would undergo a pH probe, but a pH probe study that is negative actually only excludes acid reflux. So if we really want to exclude alkaline reflux, we have to actually do an impedance reflux probe. Cystic fibrosis is not common in Asians, but we are starting to see a lot of mixed marriages. We're starting to see a lot of foreigners. At the university hospital, we also see a lot of Middle East people, and they do actually have quite a high incidence of cystic fibrosis. So the hallmarks, very thick, sticky mucus, very salty sweat, and you can treat with the empirical antibiotics and it will not work, because the bugs are different, the Pseudomonas, and also very specific to cystic fibrosis. Many of these children would have actually polyps. Polyps are not at all common in children, but when it happens in children, we have to exclude cystic fibrosis. For example, this kid, you can see it's a very broad nasal dorsum, right? And the parent came to me because of broad nasal dorsum. There was no obstruction of the nose, no difficulty breathing. The kid had difficulty breathing, but they couldn't complain, right? Because the kid who has grown up with nasal block never knows that he has nasal block. But the mom came because she wanted me to make the nose bridge smaller. And so when we actually went into to surgery, it was quite shocking because it was pretty asymptomatic, but it was, I'm not supposed to show actually the name, right? I'll get into trouble. Okay, so but the whole area was actually filled with polyps and it was filled with Pseudomonas and every sinus was infected, but the kid actually had no symptoms. So many kids do not complain. I think that's an important point to note. Primary ciliary dyskinesia, also not common in Asians, but some of the things that you can suspect, okay, if this kid has rhinitis at birth, starts very wet nose at birth, very bad asthma that doesn't seem to get treated, very chronic wet cough. If you see a heart that is on the right side instead of the left, it's an cartilaginous syndrome, situs inversus, that's easy, you can diagnose that. But in ENT, if there's a very severe recalcitrant discharge, even after grommet tubes, this is something we have to actually exclude. The guidelines follow the EPOS, but we have to tailor in every kid the management, and we must remember that the guidelines actually only reported results in patients without any normal patients. Okay, so patients with syndromes, patients with some other diseases are actually excluded from the guidelines. Antibiotics are needed for about 10 days, and they only help in acute rhinosinusitis. They only help short term to actually decrease the length of the symptoms. So you need to treat about 8 patients to get 1 patient to get better. Okay, so the evidence is not very strong there also for acute rhinosinusitis. If it is not very severe in acute rhinosinusitis, but if the symptoms are very long, okay, stay very long, you can start treatment with amoxicillin. Penicillin allergy, you can start with azithromycin or clarithromycin. If it is severe, you want to add add a beta-lactamase antibiotic, and if there are complications, definitely admit for IV antibiotic. Again, topical corticosteroids are actually just an adjunct, and there have been not much evidence for decongestants and douching, but I do it anyway, okay, because again, you have to remember that it may be because there are no trials done, yeah, does not mean that it is really it is bad, huh? It doesn't work. So for chronic rhinosinusitis, I think the important thing is to actually treat the underlying diseases. So if there's allergic rhinitis, if there's immunocompromise and all that, to look out for that. And in chronic rhinosinusitis, we treat only the acute exacerbations. And this is not even from the EPOS paper, because it actually follows, if you notice, 1996 guidelines, very long ago, the guidelines. Okay, there's not very good data. So we treat with 2 weeks oral antibiotics. If it is getting better, some improvement, you can AIV a second course of 2 weeks. And if it still doesn't get better, you should try to refer so that we can get better cultures. Yeah, after decongesting the nose with a flexible scope, the antibiotics should be directed to the bug, and very rarely you need a third course. And if all else fails before you do surgery and all that, you should admit them for IV antibiotics. Okay, and then treat reflux medication if there is reflux, because in some papers they have shown that it actually avoids surgery in those with pH probe positive. Actually, high chance of the rhinosinusitis getting better if there's reflux. And functional endoscopic sinus surgery has been shown to be safe for children. Yeah, now there's a very good safety profile in adults, and even for children, if we do it very carefully, guided with image guidance, after all medications fail, they have been shown to be effective. Antral lavage, inferior meatal antrostomy, and Cotwell lung operations, because of the risk. For a very young child below the age of 7 years old, the floor of the maxillary sinus is actually higher than it's actually still below the level of the tooth. It's actually very nearby, so it's actually quite hard not very safe to do an antral lavage and all that, and there's not very good data to suggest that they are effective. So as of now, it is not recommended. Thank you very much.